Okay, a very good morning, afternoon, or evening to everyone. I'm Julie Tarode, a proud member of the Executive Council of the African Organisation for Research and Training in Cancer, more commonly known as AORTIC. It's my pleasure to extend a warm welcome to everyone on World Cancer Day to this dedicated AORTIC webinar, which is a collaboration between our radiation oncology and advocacy special interest groups. So it's also good timing to introduce you to my co-chair, Dr. Surbi Grover, who will, I'm sure, need no introduction as a committed radiation oncologist working in Africa. Surbi is the co-chair of the Aortic Special Interest Group on Radiation Oncology, and I'm sure you all know Associate Professor at the University of Pennsylvania. So welcome, Surbi, and thank you for developing this session with me. We've had some interesting new publications on the status of radiotherapy services across Africa in the past months, and this webinar will share these new insights, but we'll also be asking our speakers to kick off the discussion on the question how we can collectively use this data to influence our country leaders towards more investment in radiation oncology. As we know, this is critical to cure key cancers like cervical cancer and an essential treatment for approximately 60% of cancer patients in Africa. So we'll begin with 5 short stimulus presentations, and we welcome your questions throughout in the chat. And I also encourage you to join the discussions in the panel discussion that follows, where we discuss ensuring access to radiotherapy for African cancer patients and how new data can stimulate new dialogues with policymakers. So without further ado, I'd like to introduce you to our first speaker, a longtime friend and contributor to the Global Cancer Control Movement, Dr. Fabio Nyo de Moraes, a radiation oncologist and associate professor in the Department of Oncology of Queen's University in Kingston, Canada. Fabio will be introducing the new LINAC shortage index and sharing insights from the African data in his most recent publication. So over to you, Fabio.
Thank you, Julie. Good morning, everyone from Canada. It's my huge pleasure to be here today and to have this opportunity to discuss the findings of our work on the World Cancer Day with our friends from AORTIC. It's again, a huge pleasure. So I'll share my screen, and without further ado, I will start my presentation. I'll be happy to take questions at any moment during or after the presentation. Are you able to see my full screen?
It's still in presenter mode, so if you could, just put it on.
How about now?
There we go. Yeah, that's fine.
Yeah. Perfect. So as Julie said, I'll be presenting on the Global Linear Accelerator Requirements and Personalized Country Recommendation, our cross-sectional and populational-based study that we recently published at Lancet Oncology. I have no conflicts of interest to declare related to this work or any other work. So I will start by giving some background. I know most of you are aware, but radiotherapy plays a crucial role in cancer treatment. We know that there is a global shortage of radiation services, majorly on low-income countries and also in middle-income countries. And as we know, the number of cancers, so the incidence of cancer is growing, and by 2040, 2050, low and middle-income countries will be responsible for the most cases, and there will have an increased global need for radiation treatments. The 2015 Lancet Commission already reported that scaling up radiotherapy could save 26.9 million life years in low and middle income country. They also report a substantial economic return on investing on radiation. So we actually find out that radiation can save lives, and also radiation can give money back to the countries, which means it is an easy decision to make. However, we have been struggling on the last couple of years to see progress. There is a new Radiotherapy and Theranostic Commission published in 2024 that also showed to us that the issues still stand, and that there is a key challenge in the development of radiation capacity. And the big issue is increasing the availability of Linux, the machines, and also human force for the treatment delivery. With that in mind, we thought that we had to do something better. In the past, we only quantified the gaps on radiation machines, and then we decided to create an index to help us to prioritize the location and how to bring radiation equipments to countries. We start with a cross-sectional study in Brazil, and then now we moved to a global study. So we developed what we call the LINAC Shortax Index, which is a relative measure of radiation demand and supply that takes into consideration cancer incidence, country-specific treatment needs, and country-specific availability of radiotherapy centers. With this new study, we aim to calculate the index for all countries with available data, classify the countries according to their degree of radiation shortage, assess the correlation between LCI and country level, and estimate investment needed to ensure provision of radiation globally. We included 181 countries, from low-income countries to high-income countries. We used as data source GlobalCan observatory data for incidence, radiotherapy available centers and machines from DIRAC, and the economic indicators for the World Bank. Countries with missing cancer incident data were not included in the analysis. So you're going to be noticing that there are some countries from Latin America, Southeast Asia, and Africa that we could not calculate the LCI, majorly because there was no incidence reported on the GlobalCan database. So how we define LCI and the grades, because these are the most important metrics that we reported on our paper. So number one, the LINAC Shortax Index quantify the need for LINAC by comparing the number of cancer patients requiring radiation with the available LINAC capacity. So with that in mind, we used the metric reported by WHO, that is 450 patients per year. And then we take into consideration the number of machines that the country has, and also the incidence, and also the radiation treatment utilization rate that was published previously by our colleagues from Australia. So LCI, if it's greater than 100, and it can vary in many degrees, it shows to us how much shortage of radiation is there. So it's a LCI of 130, meaning that there is a 30% shortage on radiation. We also categorize by the need of additional machines. And when we report as grade 0, there's low need, or even if you say like numbers, and if they were well distributed, there will be no need of new machines. Grade 1, moderate, grade 2, high, grade 3, very high, and grade 4, there was no LINAC available in that country. So for the countries that there are no LINAC, we always try to bring those countries to the top of the list. So we should prioritize at least having one center with one machine. We also did the cost estimate based on the Van Dijk cost model that incorporates equipment, acquisition, construction of the centers, and human resources based on an 8-hour schedule. I know there's many places that works more than 8 hours per day. I'm from Brazil, and there was many times that I did work with radiation from 6 a.m. To 12 p.m. Or midnight. So we did calculate inflation between 2022 and 2024, which is a limitation, and we should address that. And then we also calculate the cost of replacement of existing machines, because some machines will be obsolete by 2045. So statistics, descriptives, ANOVA, and Fisher test to compare. So what we see, what are our results? So first, we know that the cancer incidence is increasing from 19 million to about 28 million from 2022 to 2045. So it's a 50% increase. In 2022, there was a reported 14,792 LINACs globally, and there was significant disparities between high-income countries and low-income countries. Just to put in perspective, the median number of Linux in a high-income country was 36. The median number of Linux in low-income country was 1. When we look at our index, there are significant disparities between high-income countries and low-income countries. So light blue, light green, and green is almost like light green, no need or low need, and green is like at least like 30% or less needs of increasing capacity. So you can see most of these countries are in North America and Europe. If you look here in South America, you're going to see something around 130 to 300. So a 300% increase needed. And if we focus on Africa, you're going to see that many countries has a LCI of more than 300. And there's a couple of countries in gray here that there was no machine, so we could not calculate. There was no incident, so we could not calculate the LCI index here. So there was lack of incidence date for cancer data. So we also had some countries with no machines. So then they are grade 4. And then those countries we also prioritize when we're putting our rank out. So if you look here on the coast, you're having some countries like Guinea, Guinea-Bissau, or Sierra Leone with no radiation machine at the time of our analysis. And then if you look on the other coast, you have like Somalia and other countries. So there's always special places that they will need more attention and more investment. So when we compare the countries or regions, if we look at the median LCI, globally, it was 130, telling us a 30% shortage. But then when you compare, if you see upper middle income, 33%, and then low income countries, 1,523, showing to us there is a huge need for increasing capacity. When we look at numbers, so grade 4, no machines. So we had majority of these countries being low income countries or low middle, and then grade 3 with a very high need. Low and middle were most common presented. When we look at countries itself, there's only 8 countries where the existing Linux capacity in 2022 is sufficient to meet the projected need for 2045. So meaning that theoretically there will be no need for further investment. However, this needs to take in account machines that will need to be replaced and also distribution of those machines. Overall, globally, investment is need. There is going to be a need of 16,365 new Linux to meet the 2045 demand, and a total investment of $123.9 billion. So the machine here, the figure here just highlights the number of Linux needed for 2045. And the changes on the absence of investment. So showing that without investment, countries are more, there is a significant number of countries moving to grade 3 or from grade 1 and 2 to grade 3. So finally, we know that there is this global disparity in radiation access. Low-income countries and low and middle-income countries have a higher cancer burden, but lack of sufficient radiotherapy infrastructure. We developed the LCI to highlight this disparity and help to guide investment. Addressing the global Linux shortage requires target investment and collaboration to ensure equitable cancer care. Thank you, and I'm happy to take questions and also to connect for further collaboration and to work together to better analyze and use this data. Thank you.
Thank you so much,
Thank you,
Fabio.
Fabio.
There's a lot of information there, and I was quite shocked at that slide that only 8 countries seem to be suitably at a suitable level for radiotherapy by 2045. So a lot of countries need to take note of this information. Obviously, this is an African discussion, Fabio. So a quick question to you. You know, if I'm looking at your paper and I live in a country that's not on the index, How can I use the index, do you think, to still sensitize my own government to the need for investment?
Yeah, that's a great question. So trying to help all these countries, we actually develop appendix, which is together with the paper online. We listed every single country, and we also listed the radiation utilization rate needed for that country. Because we didn't have data on cancer incidence, we could not calculate. But what you can do is actually, if you have any cancer registry, or if you can estimate based on a neighbor country or other country that has a similar profile as your country, it's a very easy for you to calculate the index, or you can reach me out with an email, and I'll be happy to calculate for you or for the country that need. So we try to put as much information as possible for all countries on the appendix, so people will be able to think together with the policymakers, and they have almost all numbers there. And I'll be happy to help them to calculate the index and the grade if they need.
That's
Awesome.
super, Fabio.
Fabio, there's a couple of questions in the
It's always so valuable when you're talking to policymakers. Sophie, I'm sure you have a couple of questions. And did we have any questions in the chat?
There's actually a couple of very good questions in the chat. Can you hear me okay?
Yeah.
So the first question, Fabio, was, did we consider functionality in the modeling? So if the machines are functional or not, and did you account for both private and public? I would imagine functionality is tough because it's from direct database, but public and private were all accounted for. Is that correct?
That's correct. Both are correct. The functionality, I think, is the most difficult one because we don't have that data in the system, which is something that I think we must do better in the future. So we need to create a registry or a database that we can track new machines, which ones need to be replaced, which ones are active, not active. It's huge investment for one single machine, so we should be able to track that. Regarding the availability, what we consider was actually it's very hard when you're doing analysis to compare private and public sector. For instance, I can give you an example. 80% of the machines in Brazil, they are to serve the public system, but there are 20% of the machines that they do mix or they do private centers. But sometimes we don't know the percentage of work that they do on the mix side. So it's majorly private, majorly public. So it's another limitation because that data is not clear. So we try to actually do all the calculation and estimatives based on the incidence for the full country, acknowledging that there is some private machines that will be treating a smaller ratio of the population, which might school the index for one side or for the other side. But the only way for us to improve that is, again, is having like a prospective registry that we can actually collect that data and make sure how we are using our machines.
Absolutely. No, I mean, this is really great data. Most of the machines are public. So, so the assumptions you're making are correct. The other question that's really good from Kirsten is, are we accounting for hypofractionation and perhaps increasing use of hypofractionation when considering the demand on the machine?
Yeah, that's a really great question because we use the models developed by our colleagues in Australia, the RTU rates that has been published in the last couple of years a couple of times. They always update based on new guidelines and new indications, which has been addressing this issue of new hypofractionation for breast or for prostate or for other cancers. So that has been taken in account. And for every single country, based on use of radiation, presentation of the cases, they have a different radiation utilization rate, which we acknowledge that they have been taking into account hypofractionation and even like SBRT when is the case. However, our field changes very fast, so I'm pretty sure there are some limitations there. And also, there's a survey that was published by one of my colleagues, Dr. Daniel, with the Astro Gyro team that look at the patterns, and there's different patterns when you're treating breast, prostate, and metastatic cancer based on fractionation and what fractionations people are using. So we try to as much as possible, but I'm pretty sure if you look at your specific country, we might find some differences. And that's why we did the exercise with Brazil. And then Brazil, we were able to see every single state and even go to a city level to kind of like calculate. And I'll be happy to do that in the future with a specific country or a specific region.
Yeah, wonderful. I mean, this is really great work. And I wonder if we could come up with a formula with all the key variables, and then we can sort of input the the variables per country and get an output. And this would change over time based on technology and based on some of the other presentations that are coming up as really changing our field moving forward, right? So I think this is a really great segue into Manjeet's talk. Julie, if that's okay for me to go ahead. Yeah, so our next speaker is Dr. Manjeet Dosanjh, and she is, also doesn't need an introduction. She's a close colleague from ICC, and this has been a major passion project of hers while she was at CERN, and continues to be at Oxford, as well as continues to work with ICC in building a LINAC prototype that would be more suitable and durable for LMIC settings and high-income settings. So Manjeet, maybe...
Yep. Thanks a lot, Surbi. Let me see if I can try to share my screen.
And yeah.
I have to be allowed to, okay.
Yeah. And this is great. While Manjeet is doing this, this is, leading up to Fabio's work on looking at the shortage, and both Manjeet's talk and the next talk after that with Jeanette will really help us sort of think about how we can best use the resources we currently have and put that in perspective. And hopefully, as these equipments and softwares become more and more common, it will help us adjust our needs in terms of the machine and the infrastructure into the solid.
I'm not allowed to share my screen. Maybe,
Mira, can you just make sure? I think you can't have too many people as hosts, so you maybe have to deselect someone before Manjeet can share.
Will do.
Thanks.
Otherwise, I don't want to waste a lot of time. So what I'll do is I'll pass it on to either Julie or Surbi, and somebody else can show my slides. Yeah. Sorry about that, but for some reason I'm not able to do that.
Yeah, if you can send them to Belmira, then she can project for you.
Okay, thank you. So why don't you go with the next speaker, and I'll just do that, okay?
Yeah, so I mean, both of these talks are in some ways related, so maybe we can go to Jeanette next. So Jeanette Parks is the chair of radiation oncology at the University of Cape Town, a close colleague and mentor and friend. She's been spearheading many radiation oncology education training access initiatives across the continent, and particularly in South Africa. And today, Jeanette's going to be talking to us about a project she's been working on with close collaborators on thinking about how do we actually automate some of the planning in the clinic and get the most out of the machines that we do have, right? So have a quicker turnaround and get good quality plans through automation and AI. So Jeanette, the floor is yours.
Thanks, Surbi, and thanks, Julie and AORTIC, for the opportunity to present on archery. Let me see if I can check, because I see I'm also not a co-host.
Oh, there we go. Jeanette, it's working. Perfect.
Okay. So I'm talking about the archery study today, and how can AI-assisted services contribute to filling the radiotherapy gap. And I don't have a conflict of interest, since this is the subject of the talk. And you've seen a little bit already about barriers to accessing radiotherapy access in low and middle income countries, but it's not all related to the machines. You can see the lack of machines. We're quite used to looking at these maps, and it's estimated that only about 40% of middle income patients and 10% of lower income patients have access to radiotherapy. but this is older data compared to Fabio's data. So maybe we should update our slides with Fabio's new data. But one of the other issues in terms of access is lack of expertise and lack of trained staff. And if you look at the data article in the Red Journal, you'll see that the expectation is that by 2035, we will need an additional 30,000 radiation oncologists, 22,000 medical physicists, and 80,000 RTTs. So closing this gap could save more than probably 1 million lives per year. So if we look at market-led innovations and public health goals, there are four forces driving global healthcare trends: unsolved medical needs, the explosion of information, growing global consumption of healthcare, and pressure to contain healthcare costs, which is a huge one. And this is leading to the next generation of healthcare products. So the WHO's Sustainable Development Goals highlight the importance of digital technologies such as artificial intelligence to contribute to advancing universal health coverage. But it's absolutely imperative that these new digital health technologies are not only clinically robust, but also affordable for those of us that live in low and middle income countries. So the radiation planning assistant, which we affectionately call the RPA, was started in 2016. It was funded by various different grants from the NCI, from Wellcome, from CPRIT, and MD Anderson. And this work has been led by Professor Lawrence Court, a medical physicist at MD Anderson. And it was designed specifically with the goal of trying to cut down the number of human resources that were required for radiotherapy contouring and planning. And he's worked closely with partners in South Africa, Tanzania, and various other countries in the world to try and automate the processes of contouring and to automate planning in different areas in the body. And this has been shown quite significantly in a number of different publications to reduce the time significantly in terms of contouring and in terms of planning. In fact, it goes from weeks down to minutes. So there's a number of different publications. You can see across the bottom, it's ranged from contouring, has led into simple planning, 3D planning in the pelvis, 3D planning in the head and neck, and has moved on now to VMAT planning in breast cancer, in head and neck cancer, and even to more complex areas like craniospinal radiotherapy in children has been one of the projects that Lawrence has been involved in. So he has a number of different projects, and this is kind of what it looks like. I challenge you to find much of a difference between Plan A and Plan B. Lawrence has this great presentation where he makes the audience vote on a number of different cases about which one is the machine-generated plan. But for the purposes of today's talk, I thought I'll just show you one example. So Plan A and Plan B is generated by a machine, Plan A by a human. And this is planning that can take a human days to weeks, depending on the experience of the planner. But the radiation planning assistant can do exactly or very close to that plan in just a matter of minutes. So one of the concerns about AI, and one of the things that concerned Lawrence, was that there's actually quite limited studies looking at AI. Or studies that are done in a prospective way. There are quite a number of studies, but the majority are very small. They're less than 50 patients. They're single-center studies. They're in high-income settings. There were no studies from low and middle-income country settings. And a lot of them had significant methodological concerns and a moderate to high risk of bias. They had limited or no economic assessment. And so the AORTIC trial was developed, and this is a prospective observational study of the use of the RPA, or artificial intelligence-based radiotherapy treatment planning, in cervical cancer, head and neck cancer, and prostate cancer. And it's being led by Prof. Ajay Agarwal from the MRC Clinical Trials Unit at the University College of London. So there are a number of different centers involved in the study. Here they all are listed on the right and shown on the map on the left. There's quite a large CTU team led by Claire Murphy, Matt Nankerville, Carol Roach, Isabella Jacques, Ruth Langley. Julie's involved in the study as well. And it is being coordinated through the centre in London. So this is a prospective observational study, and it's looking at these specific areas which were chosen because they're areas which have different issues. The primary outcome measure is overall treatment plan acceptability, and the secondary outcome is time and resource savings, and also the impact on budget of auto planning. The study is planning to accrue 990 patients over the time period, so 330 per tumor type, and each cohort is assessed separately, targeting a 95% plan acceptability rate. This is on contouring and planning, and time measurements are being taken for the time taken to contour, the time taken to plan, as well as the budget impact as a secondary outcome. So these are the institutions, and these are the number of participants enrolled. This was updated last week, in fact. So you can see that the University of Malaya, the King Hussein Cancer Center in Jordan, Tata Medical Center in Kolkata in India, and Tata Memorial Mumbai, India. Two centers in Cape Town, South Africa, Groote Hospital and Tygerberg Hospital. And the accrual so far on the study is about 447 patients out of that 990. You'll see that our center, in fact, I'm proud to say, has enrolled the greatest number of patients to date. And the largest numbers of these patients are CA cervix and CA prostate patients. So there've been a number of challenges, also a number of opportunities in working with these workflows. So the patients, there's no risk to the patients. They're not treated on the AI-generated plan or AI-generated contours. They're treated as they would have been, but they do have to give consent for their data to be used. The data is sent to MD Anderson, and an AI process happens as a parallel process to the manual planning, and everything is timed. There's quite complex data flows. It's quite complex managing 10 different institutions, 7 different countries. There's different contracts at every center, different data governance, different HREC requirements. It's also been quite tough defining a gold standard. I mean, who makes that call, right? Decision-making regarding which guidelines is the gold standard, which is the international standard, how do we raise the bar? And so there's quite a rigorous QA template, which has been led by UK RTT QA. There's also a component of capacity building. This is the first international radiotherapy trial for many of these sites. And so dealing with the normal processes that go along with a research study, a radiotherapy-related research study, has been a first for many of the staff, and there's been a component of having to learn how to do that. For the first time also, and I don't think this is just in low and middle income countries, we've created patient and public involvement groups at each of the study sites to advise on different aspects relating to this research specifically, but research in general, and also to advise on research capacity. So that's been a really interesting journey, and that's been actually led by Julie. So I think that's as much as I can say right now, Serbi and Julie. So we're about halfway through our accrual. This is my team on the left of consultants in beautiful Cape Town on top of a building in the CBD. And on the right, I thought it was only fitting that we put a picture of our registrars in training, since they do a lot of the contouring, and they also do a lot of the timing of the contouring and planning. So a big thanks to our consultants and our registrars involved in the study, and also to our very committed research fellow Zaida Amle, and of course the whole MRC team led by Ajay, and then to Lawrence for his ongoing collaboration. So back to you. Thank you.
Thanks very much, Jeanette. It's a very exciting study, and what I like about it is that the outputs are being quality assured to the highest standards, international standards. We're not dumbing down the quality or anything. So those data will hopefully show that this tool can be used in all countries. And we're halfway there, as you say, on congratulations on the excellent recruitment at CTU. So we're hoping to finish by the end of the year. But a quick question to you, Jeanette, because I know a bit pressed for time, but how would you see that being used, this RPA tool being used once we have the supporting data? How do you see it maybe helping to expand access to radiotherapy in your environment in South Africa?
Well, one of the things that I'm really excited about is the fact that Lawrence has negotiated with the FDA and with MD Anderson as well to make this tool available free of charge to low and middle income countries following the study. So I think that's been one of the real reasons why so many low and middle income countries have been so keen to take part in this study, because potentially it's a tool that can be used free of charge in the future. But I think what it provides is the possibility to do really excellent contouring and planning with less staff in areas that are not able to recruit, not able to retain. We all know about the brain drain in low and middle income countries is an ongoing issue where the best staff are recruited from high income countries and move on quite quickly. So I think that this will provide the opportunity to do high quality planning for patients in areas where staff recruitment and retention is really a major problem. And it also speeds things up, Julie. I mean, I was blown away with the craniospinal study that we did. It literally took 5 minutes to plan a craniospinal child using the tool. So, if we're looking at those kind of timings, I think for our high throughput diseases like CS cervix, prostate, breast, if we can develop tools like this, I think it will really make a massive difference to those areas.
Absolutely. So it could mean that people coming in for a scan and actually starting treatment literally the same day, rather than sometimes many months. Yeah.
Yeah, especially for the epithelial malignancies, as you know.
Yeah, it's very exciting. So let's keep an eye out for those data. So let's go back to Manjeet. We have now got your slides, I think, Manjeet.
Okay.
Your patience.
Thanks a lot.
And please introduce us to the work you've been doing and the Stellar project.
Okay, thanks a lot. Thank you for the possibility of presenting some of the work we've been doing in Africa. And also just to say, following on from Jeanette, I'm here actually in London because it's shaping the future of AI in healthcare. It's one of those first such global conferences being organized by the National Health Service and the Royal College of Radiologists. So, precisely, it's a good thing to be following from what I've just heard, because that's what we are trying to see is how you can leverage AI to try to help. So, yeah, and I don't think we need the first slide. So next, please. I hope somebody's going to help me. Okay, so the thing is, Fabio has already presented some of this, but this is, just to say, of course, there have been significant advances in cancer treatment ever since the first data came out with the IAEA and the Astro Hero, as well as the global task force. However, in spite of all these advances, there are still huge disparities. And as has been alluded to, the Lancet Commission that just came out in September, I was also fortunate enough to be one of the people involved because we presented African data on there. So next, please. So as I said, even though there have been lots of advances, but we still have a huge challenge in disparities. And so both in Linacs and in CT scanners. So we can go, I just want to rush through these because I'm very conscious of the time. Next, please. And then now let's talk about the fact that, the projected workforce for shortage, which is a big, huge issue we've been discussing yesterday and today here in London. and 18 million globally. Oh, no, can we just stay just for 1 second, the last one, please? Okay, so 18 million globally, but a third of those are going to be in Africa. So, you know, this is going to be a huge challenge. How do you try to handle the workforce as well as the technology? So 80% of the population in LMIC is without access to trained oncology providers. It's really quite shocking, some of the numbers we are looking at. Next, please. So in contrast to Fabio, what we did was we actually concentrated on Africa because we started looking at the access to Linux and RT technologies already when we were in Botswana. Surbi, who very kindly hosted us, and it was really interesting to see this. And what we understood was that it's really important to try to get detailed data from the ground, because this is always one of the big challenges of the reality of what's functioning, what isn't, and so on. So we actually, at that point in 2018, 2019, there were only 28 African countries that actually had access to Linux, which now has gone up. However, nevertheless, if you start looking at contrast, you know, 1.4 billion with 400 machines versus, you know, 300 million with 4,000 machines in the US. So still there are major challenges. And even within Africa, 60% of the Linux are in 3 countries. So what we've been trying to do is look to see where the challenge is, what it is, and how can we try to improve access. So next, please. So we, as I said, were able to, thanks to Taufik Ige, who's online, as well as all the collaborators, such as Surbi as well, that we were able to connect with all 28 countries in Africa which had RT. And then we also looked at the high-income countries with our collaborators from UK, USA, Canada, Switzerland, Jordan, etc., just to see, to compare a sort of equivalent number of Linux as to what are the differences. And, you know, can we pin down what really doesn't work so easily and how could we try to address that? So next, please. And you know, and one of the things that was really not surprising, but still shocking in a way, is that not only a number of countries have very limited access to Linux, you know, because of the GDP and the mortality and all of these data are clear. I mean, we are so well served in the UK and Switzerland and so on. So just keep an eye on this as to where the Linux mortality is. And if you look at the next slide, please. So not only we have shortage of Linux, but these are also the countries where the Linux keep breaking down. So, you know, even if you have few machines, how do you make sure that you actually stop them breaking down and have greater throughput? So this is what we've been concentrating on. So next, please. And so what we found, what we looked at were what were the main reasons for the Linux downtime. And amazingly, 70% of that is access to spare parts. You wouldn't think that should be a big challenge, but we know it is, because during the COVID era, you will have seen the very touching story about the spare parts being in South Africa and our lady in Zimbabwe not being able to have access to breast cancer treatment, saying, you know, what are the challenges if you're not treated for that long? And of course, nobody even knew because they've not had to deal with something like that. So, and then one other, what doesn't work, and 2 is how quickly these things can be fixed. And we wanted to see how to be able to overcome that. Next, please. So what we've done is, so, you know, this Project Stella is smart technologies to extend lives with linear accelerators. So it's really to look at, you know, which things break down, how can we try to make them more reliable, can they be easily fixable so you don't have to have specialized technicians and engineers, because this is, as you know, is always a big challenge, and we want something a bit more like Lego pieces rather than having to have everything so that you have 6 months of stoppage time. And the reason why we really concentrate on this is, I didn't want, I mean, you told me, Julie, 10 minutes, so I wanted to be really short with my slides. I mean, there was a situation of Madagascar that they were down for almost 8 months. because they needed a spare part. They had a service contract, but the company would not give them spare part without them paying up front, and they just couldn't afford it. And this is really a situation that should not be possible, really, when you think about it. So this is why we're thinking about, disruptive, innovative treatment systems to improve access, quality care, and really leveraging the integrated software and the use of AI, exactly what we've just heard and also what I've been hearing yesterday and today here in London. And at the same, trying to have an enhanced training, education, mentoring system, since machines don't train patients, people do. So we have to be able to do things side by side. Next, please. So the idea of Stella is, can we reduce the cost besides the machines? And can we reduce the head count so that the number of experts needed is also lower? So next, please. So and you see, while we're looking at the machine, we realize that education and training is a key issue. And we were very lucky enough that we've just been funded by the UK African Physics Program, the project called Sapphire, and we are going to do a training program with Pretoria, and Sorbi is the lead from there in South Africa and Ghana. Basically, the object is to train junior medical physicists in data collection, in analysis, but at the same time to train them so they become much more operational and familiar with the machines so that their breakdown time is reduced. And then at the same time, compare the performance of the designs. And the thing that for me sitting here is really surprising, Pretoria has 5 machines in Slimbeko Hospital. All of Ghana has 5 machines. It's just, it's really amazing. And how can we try to get to the next steps so we have more machines, more experts, and less downtime? So next, please. And so really, Stella is a vehicle for leveling access radiation therapy globally. Because, the UK has been talking about leveling ground in the UK, but we want to do this. We would really have a wish for global access. So but increasing local radiotherapy provision, lower staff footprint, greater uptime, using predictive and preventative machine maintenance, because we have a number of projects involved in this, and high quality image guidance and hyperfractionation to try to increase output, and network and data driven. And of course, we can't do any of that without leveraging AI and virtual learning tools. And of course, there's been a lot of caution about what do you, and so on. But with all of those caveats, it's really important that we actually have to look at all of these in order to provide greater access and start to reduce disparities. And as a final caution, sitting in the UK, high-income country, as we know, Julie, but even here we have challenges in remote and rural regions, and the US even more so. So these solutions are not just for places which are very well furnished, but also, LMICs, but high-income countries too. So anyway, I just wanted not to give you too many details because I'm trying to keep to my 10 minutes, but that's just Stella in a nutshell.
Thank you so much, Manjit. And I'm sure, for us advocates, this is a lot of interesting information. So I encourage you to look at the papers from the Stella project, because it is starting to chip away at all the different reasons why we don't have access to radiotherapy. A bit of a provocative one, Manjit, for you. Someone said, the main issue is price. How do you see as advocates we can rationalize the price?
So the idea is that these machines should be much cheaper, but we know that price of the machine is not the only thing. So there's going to be robust, easier to maintain, fewer experts, but of course, and within a price we are talking about, there shouldn't really be any more than a cobalt machine, if not much less.
Yeah.
Okay, so the price of everything, right?
And one machine treats many patients. So let's not forget what the impact of just one machine is.
I was going to say, for our model, currently machines treat 400 patients a year, more or less. Our sterilized, the estimate is about 800 patients. So
Right.
twice as many patients, yeah.
And we could say at least 10 years of life.
At least.
Yeah.
And particularly since the parts are renewable and easily renewable, you don't, I think, yes, absolutely. And the main point we're looking at is keeping those ideas in mind, robust and maintaining and easier. And it should be possible that the local staff don't have to wait 6 months to do what they have to do, because otherwise they're not fulfilling and their purpose or fit for purpose.
Yeah, and I agree with you that sort of predictive and a preventative maintenance aspect can play a big role.
And you see, and this is where AI is such a big player, because I didn't talk about which parts, but we know that things like, the MLC breaks down a lot in in LMICs. But, we are comparing the data with Oxford and Cambridge and Exeter and King Jordan. It's not that the MLCs don't break down. It's just that they're fixed so quickly. They have the spare parts. They know what to do.
Yep, and they also have multiple machines. So
they have multiple machines, so you can transfer the patients.
It doesn't stop the service, whereas in many countries it does. Absolutely.
And we do know that we don't need as many leaves to be able to do the conformality we do, and that, of course, will make them a little bit more robust. So we are working on various parts, but starting with MLC first, because that was the biggest showstopper actually in what we were looking at.
Okay, thank you very much. I hope people are happy to stay on. I know we've run over time a little bit, but I think it's a very interesting mix of presentations we've heard so far. So let me hand over to the co-chair of the Aortic Radiation Oncology Special Interest Group to offer some reflections. That's Dr. Adedeo Joseph from the NLCC in Lagos, Nigeria. So over to you, Ade, for your reflections on what you've heard so far.
So thank you very much. I'm sure everyone agrees with me that those were very thought-provoking presentations. I do have just, I think, 3 slides. I obviously can't talk about the projects better than the implementers, but I did, let me just see if I can. Okay, so are you able to see my slides?
We can, yes.
All right. So, today we're talking about LINACs, radiation oncology, radiation therapy, and Africa. And I'm just going to try to speed through this in the interest of time. And so if we look at the LINAC shortage index, and what it does is that we do see that sub-Saharan Africa especially, and, LMICs have a significant LINAC shortage, and that shortage, for me, what was more notable is the fact that we have a shortage, but then it's even going to worsen. In my mind, things are getting better, where countries are buying machines and access is improving. But what this shows us is that it's not really improving, and things may not improve if we don't take action. And we know what the challenges are. So power supplies, training, proficiency, national funding, and policymakers' commitment to these things. And so what are the things that need to happen? We need to invest in infrastructure. We need to train and build capacity. Very importantly, we need funding, and policymakers have to be made aware of what is important, where to put money. And I think one of the things that we also need to, personally, just to inject this bit, is one of the things that we also need to do is insist on certain things. We tend to, in Africa, accept that certain things are not going to be available to us, and we've learned to make do. While we're doing that, we do need to let the policymakers know that, at this point, we must have this, or we're not going to be able to move forward. And technology is just, the impact of technology cannot be overstated in these things. And then again, to summarize Project Stella, what is the project trying to do? Build LINACs that are, and it's interesting how that thought never occurred to me, to think that it's possible to have a LINAC design that's built specifically for Africa, and the things you wouldn't think about. So in my center, as a real example, we've had multiple downtime, because we have the power going on and off, and then the power surges impact the machines, and then the cool down. The other thing is climate. We've had issues with the chiller, where the chiller isn't working properly because it's really hot, and then the chiller isn't working, and then it affects the machine. So these are things that the people who design it in the higher income countries might not take into consideration, because they're not experiencing those things. So, developing something that's specific for the region is just, ingenious. Affordability and accessibility, again, we know exchange rates drive up costs, and they drive up costs of servicing the machines, of maintaining them, of importing spare parts. So being able to develop them locally is going to, eliminate or at least mitigate that. And while all of this is being done, advanced technologies are being integrated. So we're not building machines that are poor in quality or in ability. We're building machines that can deliver the same level of care, but are going to be more durable and are going to, be able to withstand the problems that we have locally. And most importantly, the global collaboration, I think, is just the most important thing that we've seen in all of these projects. When you focus on region-specific issues, but then you bring expertise from all over the world, and especially including local expertise and people who understand the local context, it improves outcomes on multiple levels. It improves the outcomes of the projects, the things that we're developing, and then ultimately, hopefully, cancer outcomes in general. So thank you. Just very brief.
Thank you so much, Ade. That was a really nice summary. And I think your point about the fact that despite the fact that some countries do have some radiotherapy, but we're seeing the cancer burden in most African countries is going to double by 2040, at least the high burden cancers. And so that capacity is not going to be enough, even if you can eke out, its life cycle and keep it running. We're going to have to top up as well. So I think there are some important issues to get across as advocates. So I'd like to turn now to Lucy Kanga, who is a breast cancer survivor and patient advocate. Lucy, what have your thoughts been as you've heard these presentations, and how do you think we can be better advocates for radiotherapy?
First of all, I'm very excited to see that such research is being done, because you look at things like the number of hours that you have to wait to get your radiation treatment done, and you also look at the number of people who haven't been able to access treatment because machines are not working. I have an example of a friend of my mom's. She actually passed away because the cancer returned. She didn't get her radiation treatment in time. And most of the times we see people leaning into alternative treatments which aren't clinically proven because there's such a disparity or such a gap in these treatments. So it's super exciting. It's also exciting to see that people are looking at the cost factor, because this is quite something that is challenging in the region particularly. A lot of people end up in high debt because they are unable to access maybe state machines when they're broken down, or in the Namibian case, it's being upgraded right now. And so everyone is being transferred to private care, and not everyone is able to afford the amount of money that's needed. So taking expenses into account, taking the amount of time that we have to wait between treatment, all of that it's pretty exciting to see.
And do you think we talk enough about radiotherapy with policymakers? I feel like we talk a lot about medicines, we talk a lot about prevention, but do we really talk about radiotherapy? Do policymakers know what it really means?
I don't think so. I think not just with policymakers, but with the public in general. A lot of people have misconceptions of what exactly radiotherapy is. And the gap is mostly seen when we're talking about things like surgery or chemotherapy, but there's still so much room to do so much talking and so much advocating in the space of radiation therapy, because I don't think enough is done there.
Thank you. I haven't seen any more questions in the chat. Anyone like to raise any more issues or ask questions of our speakers today? I mean, I'd like to have had a panel discussion, but I think we're a little bit short of time. Sorry, Manjit, did you want to?
Because as I said, I rushed through because as I said, I wanted to keep the time. But as Nina put on the comment, I mean, with all of those things we're talking about, Stella is really the cost, not in terms of the machine, but also in terms of staffing, in terms of the power, in terms of service contracts, because actually the machine itself, as you know, okay, you can afford to negotiate a little bit on the price. Service contracts are very high, especially in our LMIC countries, because they don't have a lot to leverage. So the whole idea of our vision is, sustained access, but also reducing cost and really trying to bridge or at least start to reduce some of these gaps we have at the moment. I mean, happy to discuss offline, and also the papers are there. And one of the things that was really important to me for this 28-country African study was, as Fabio was talking about, getting data and so on, we actually did manage to reach all of those countries, and every single person who provided data is a co-author on the study that came out. And one of the challenges I had, because I wanted them all to be co-authors, is in our journals, they don't want that many authors. But this is ridiculous, because if without the data from our colleagues, we can't we can't make the next step. So I think we have to also think of that modality as well, because people have to be part of the solution as well as the problem and challenge.
Absolutely. You need that local information and data, otherwise.
And they have to be acknowledged, because they, so just to say, I mean, I don't want to take any more time, but one of the big passions and mission of mine is that it has to be an inclusive way forward. And that's the only way we're going to try to, to solve this really, really multifaceted challenge.
I completely agree with you, and we've done some work to show that African researchers are often not included in their papers that they've done a show about.
And no, absolutely. And with Ajay, we also, we did the study together with Ajay and some of the other people. So we did two papers. One was the parts and the technology, and the other one was the human resources. And then that also we have everybody included, and it's in the the Journal of Cancer Policy. But it takes ages to publish if you want everybody who's part of it to be, out there. So I think that's another challenge, because it's really important.
Absolutely. Well, thanks very much for that, Manjeet. And so I will close now. I know we wanted to have more of a broader panel discussion, but we have overrun. So thank you, everyone. Thank you to the speakers for joining us today. And thank you to our audience and many questions in the chat. So thank you very much. And let's keep in touch, because we do need to work together. And under the umbrella of AORTIC, we really would like to take this advocacy forward for improved cancer control and access to patients in Africa. So thank you very much, and happy World Cancer Day, everyone. Thank you very much. Bye-bye. Thanks very much, Lucy. Hi, Kirsten. I just actually got asked about radiotherapy at a select committee hearing. So I sent them a short